Thank you, Dr. Rana and Gujarat Ophthalmic Society for giving me this opportunity. The trabeculectomy is still the most effective filtering surgery, even though more and more surgical options like MIGS is coming up. Long-term data has shown that the efficiency of the trabeculectomy is persisted even after 15 years in 67% of the patients. The follow-up care of these patients, the ophthalmologists focus mainly on the Bleb as the functional part of the trabeculectomy. Various classifications are available which describes the clinical morphological features of the Bleb and which can assist physician to take the decision. But the clinical evaluation of this patient can be challenging at times. This graph is showing you that in initial first 2 to 3 months, there is a chance of failure, and eventually after 6 months, it becomes stabilized. So whatever is the failure, it happens in the early phase. The Moorfield classification gives you the Bleb morphology, which is an important indicator of the Bleb function. It calculates the area of the Bleb, height of the Bleb, and vascularity of the Bleb. Indiana Bleb morphological classification also includes the Seidel sign. There is a leaky Bleb or no leak. And May's Bleb appearance grading system also include the transparency of the Bleb structure. So imaging the trabeculectomy Bleb using the intersegment OCT is a promising tool to image this Bleb, and it was able to demonstrate the features of the Bleb morphology which are not visible with the slit lamp. So the assessment of filtering Bleb function with AIOS2025 is a useful tool to evaluate the filtering Bleb functions. This is a classic example of the cut section of the AIOS2025 generated Bleb area. You can see here the subconjunctival fluid space. There is a suprascleral fluid space, a root beneath the Bleb, sclerostomy opening, iridectomy, and Bleb wall. Ideal Bleb should have a vascularity similar to the surrounding conjunctiva. It should have a numerous microcyst, diffuse Bleb, and moderated elevation of the Bleb. And these on the slit lamp examination is shown here, but AIOS2025 gives better evaluation of all these features. Similar looking Blebs can have a different internal morphology as shown here. This Bleb is showing you the spongy look, while this has a large anoic space with a thin layer here, and this is a diffuse thick wall Bleb with a large cavity. At times, the clinical appearance could be deceptive. When you look at this Bleb, which is avascular, mildly elevated Bleb, but when we did the AIOS2025, you can see the thick wall Bleb with one single cavity, and this may not be a good functioning Bleb. Cause of Bleb failure is usually vascularization and fibroplasia at subconjunctival and suprascleral space. Rarely it could be obstruction of the internal ostium with the iris or ciliary processes. So coming back to the first graph that I have shown you, can we predict the early failure? Can we recognize it early so that we can prevent the failure and we can manage this Bleb better in the early phase? So the most important step in the management of failing Bleb is to recognize its presence. So with this aim, we undertook a study to correlate morphological features of the Bleb on AIOS2025 at 1 month with the Bleb functionality at the 6 months. So post-operatively, IOP was taken and Blebs were photographed, and AIOS2025 was done. 2 radial and vertical sections were taken at the most elevated area of the Bleb. The Bleb wall reflectivity was divided either in the uniform reflectivity, which is hyperreflective, which is suggestive of dense white area as shown here, and the multiple reflectivity with multiple tiny cavities of aqueous drainage. Multiform Bleb wall reflectivity again was divided into multiple internal layers, subconjunctival separation, and the microcystic areas, which could be an ideal Bleb for the function and success. The root beneath the scleral flap was defined in all these cases. So at the end of our study, we concluded that various patterns were seen, microcyst with the multiple layer or microcyst with the subconjunctival separation, only microcyst, and uniform bleb. So uniform bleb has a more risk of the failure, and the 100% success was seen with the microcyst and subconjunctival separation. So we can predict the long-term success at 1 month by doing this test. Bleb wall with the multiple reflectivity shows increased chance of success, and bleb pattern with the multiple internal layers and microcyst is ideal for the success of functioning filtering bleb at 6 months. One more Japanese study has done. Our findings are matching with this study, but they also had a calculation of the width of internal filtration site. Two eyes bleb may not have a similar pattern. They may behave differently. This is a case post-op day 10 showing the flat bleb and IOP showing the rising 14 millimeter of mercury. So should we remove the releasable suture in such case? Yes, we did release. This is the homogeneous area showing you the flat bleb, dense wall thickness. Post-release, immediately you can see the elevation with the multiple areas of the aqueous, microcyst, and the conjunctival separation. So mitomycin used with the trabeculectomy can have a dreaded complication. So the safer option was introduced in the form of biodegradable implant, which leaves behind its negative copy at the end of 6 months. So the absorption of this material creates an aqueous pocket subconjunctivally with a microcystic area away from it. And there is a complete absorption is seen associated with the shrinkage of the bleb. Is it okay? Should I continue? So this is the anoic area. On day 1, you can see the homogeneous implant. At the 3 months, you can see the aqueous pockets are coming up. Aqueous areas is seen, and at the end of 12 months, there is a total shrinkage of the implant here and good cystic spaces on the suprascleral region with a small and microcystic space on the side. Expressions were used initially, and they were showing you the position of the lens and the good bleb function. Tenon cyst is shown here, and after needling, we can see the flattening of the cyst, and at the end of 6 months, the thick wall bleb with a large cystic space. You can also use this technology to look at the positioning of the tube that has been implanted here, no touch to the cornea, and good pathway. So implication is AIOS can be used to identify the internal structure of a bleb, thereby providing the better understanding of the bleb morphology. It can predict the success at very early space, post-operative period, and there is a scope of early intervention in the form of enhancement of the steroid or needling, use of 5FU or MMC, and you can release the suture in time. So limitation of this technology is vascularity of the bleb, and leaking cannot be judged with this technology and difficult in the children. So it is a useful modality for evaluating the natural history of the implants that you have used, or it can predict the long-term success. Thank you.